disease. So ischemic heart disease, as we have mentioned in the past class, that it's a spectrum of disease. It can be classified into chronic coronary artery disease and acute coronary syndrome, which includes um, STEMI, NSTEMI, and unstable angina. First, we'll ask the clinical features, take the history, and do the physical examination. Then we'll do ECG and cardiac enzymes. If it's a normal ECG and there's no cardiac enzyme, then we'll go for the other differential diagnosis. And if ST elevation is present and new left bundle branch is present, or there is uh, true posterior or posterior MI, then STEMI is uh, one thing we can keep in our mind. And if ST depression or T inversion is present, which is suggestive of an subendocardial ischemia. And in that also, when we do cardiac enzyme testing, if cardiac enzyme are positive, then it's suggestive of an acute MI and STEMI, and if it's negative, then it's suggestive of unstable angina. So coming to the algorithm for management of ischemic heart disease, um, the initial treatment includes starting with the medical therapy for everyone, which will lead to decrease in myocardial ischemia. We use beta blockers, nitrates, calcium channel blockers, and then second thing is we have to minimize the ischemic heart disease risk factors. Like we will ask to stop smoking, we'll control the hypertension, we'll control diabetes, give statins for dyslipidemia. And the third line is we'll give the antiplatelet therapy like aspirin and clopidogrel. Second, we'll evaluate any high risk features. Like example includes low exercise capacity on stress testing. If the we'll check the ejection factors, and if the high risk features are absent, uh, then we'll evaluate if exertional symptoms are controlled or not. If it is controlled, then we'll continue with the medical therapy for future. And if it is not controlled, then we'll go for coronary arteriography. And if the high risk feature are present, we will go for coronary arteriography. And if the anatomy is suitable for revascularization, these things I will explain when I'll explain the revascularization part, PCI and CAPG. Then anatomy, if is suitable, then we'll go with PCI and assess whether the patient is suitable for PCI or CAPG. And if the patient is not suitable for revascularization, then we'll consider unconventional treatments and continue with the medical therapy. Then this all we have done in the previous discussion, how ACS is formed. Next, I will continue with how a human atheroma complication occurs into causing a acute coronary syndrome. There are two types of plaques: ruptured plaque and eroded plaque. The ruptured plaque has a red thrombus, and eroded plaque has white thrombus. So the red thrombus is more severe, and it occludes the vessel uh, lumen completely, because it has a thin fibrous cap. It has a lipid-rich necrotic core with inflammatory macrophage, which is commonly associated with STEMI and MI. Whereas the white plaque seen has no lipid core, has no cap rupture, and it is filled with smooth muscle and prostaglandin, and it is seen in young patients and females. So, patient coming with clinical presentation like oligo or asymptomatic, then we'll do the ECG, which comes to be normal. Then working diagnosis can be NST ACS, and on doing the cardiac markers, the highly sensitive cardiac troponin may not be elevated, so the diagnosis may be unstable angina. And if the patient comes with increasing chest pain or persistent chest pain, then on ECG we'll find ST depression due to subendocardial ischemia. Yeah, due to subendocardial partial incomplete occlusion, and the cardiac markers may not be elevated, suggestive of NSTEMI. If the patient comes with complications like cardiogenic shock or cardiac arrest, and on ECG ST elevation or malignant arrhythmias are present, the working diagnosis can be STEMI due to transmural occlusion, and the cardiac markers may rise or fall. Final diagnosis can be STEMI. Now, I have to discuss a concept of hibernating and stern myocardium.
आई विल
So,
थोड़ा सा ऐड करता हूँ मैं मैथिली इसमें, बस एक थोड़ा
yes,
पॉज करें। यस। सो
yes,
इसमें ये डायग्राम इज वेरी इंपॉर्टेंट। ओके, दैट इज समथिंग विच वी हैव डिस्कस्ड लास्ट टाइम आल्सो, बट इस सेशन का द फोकस पार्ट इज दिस डायग्राम। The presentation, as you can see, is not very much different in all the three types of acute coronary syndrome, whether it is unstable angina, non-ST elevated MI, or ST elevated MI. The patient can present with a retrosternal chest pain radiating to his left chest, involving the arm, or the pain can be present anywhere above the umbilicus. That part was discussed last time. And sometimes women, especially women and diabetic patients, come with what is known as anginal equivalents. They come with breathlessness, or say vomiting or syncope, or simple symptoms of dyspepsia, etc., which can be easily missed at primary level. So the take-home message would be to do an ECG if you are in doubt, because ECG will give you findings and it will lead to a eventual diagnosis. So हमें ECG में क्या क्या finding मिल सकते हैं? There are various classification, or let us say what findings that we can get is displayed in this diagram only. So if you find that the ECG is normal, but the still patient has classical anginal symptoms, what you should do as a medical practitioner, if you are in a tertiary care hospital, or any hospital setup for that matter, you kindly admit the patient there and then itself, or refer him to at least a tertiary care setup, because a normal ECG can progress into an abnormal ECG within the next few hours. So the practice should be कि आप उसको admit करिए. You have to convince the patient that okay, the currently ECG looks normal, but it can definitely be show progressive changes. So you can get changes of MI after a few hours. So normal ECG should not be sent home if the history is suggestive of anginal symptoms. Two other types of ECGs: ST segment depression with T wave inversions, or ST segment elevation. These are telltale for an acute coronary syndrome. You are definitely going to admit the patient and you are going to give a working diagnosis of an acute coronary syndrome. If the patient has a ST elevated myocardial infarction, here the pathology, इसमें क्या है pathology? It is because of a rupture of a existing atherosclerotic plug. So because of rupture of an atherosclerotic plug, जहाँ पे partial obstruction था vessel में, that obstruction is now complete and a large part of myocardium is infarcted. That gives rise to the ischemic pain and multiple other complications that we are going to see. And this particular type of MI is amenable to thrombolytic therapy. Thrombolytic therapy में जैसे IV drugs आप दे सकते हो, जैसे streptokinase, reticlase हो गया, tenecteplase. Here you use fibrinolytics, जो plaque thrombus जो बन गया है, you lyse that plaque and also avoid the further ischemia. Okay, and then later on you can go for the intervention therapy in settings where already the interventional setup is available 24/7. Then you can straight away take up the patient for intervention. So that is going to be the next part. But यहाँ पे diagnosis के लिए एक और चीज जरूरी है, that is the cardiac markers. उस पे भी हम लोग थोड़ा सा डिटेल में बात करेंगे. Any time when there is a myocardial injury, there is elevation of these cardiac markers, which include CKMB, cardiac troponin, or cardiac troponin T, or cardiac troponin I. So most of the times we in our hospitals we will find cardiac troponin T or troponin I. ठीक है, क्योंकि CKMB is not specific, it is also present in the muscle. So even muscle injury में भी आपका CKMB बढ़ेगा. So you are not very sure whether it is a cardiac injury or a muscle injury. So troponin is very specific and it rises pretty much early also. So because of advent of this high sensitivity cardiac troponin, initially we used to do only cardiac troponin. Now many centers have this high sensitivity cardiac troponin. Many patients of so-called unstable angina were reclassified into NST elevated MI. So now we are classifying both of these terms on in a single heading, that is NSTE-ACS, that is non-stimulated acute coronary syndrome. ठीक है, क्योंकि मैनेजमेंट वाइज यू हैव टू बी ऑन अलर्ट फॉर बोथ द कंडीशंस. You have to admit the patient, look for the progressive changes, and start the patient on anticoagulation, antiplatelets, and other supportive management. इसलिए हम दोनों के लिए भी उतना ही seriousness रखते हैं. And for STEMI, the management is little different, that you have to thrombolize the patient. And for both all these classes of patients, doing a mandatory echocardiography, taking a cardiologist opinion, and going for an intervention will remain common for all these different type of patients. ठीक है, तो यहाँ पे टेक होम मैसेज ये रहेगा कि एनी टाइम यू विल गेट अ पेशेंट विथ angina symptoms or angina equivalents, bare minimum thing you can do within the next 5 minutes or 10 minutes is record a ECG at that point in time. Always label the ECG with the patient's name, date, and time, and look at the findings. If it is very much suggestive of a MI or non-ST elevation, you can think of acute coronary syndrome. But even if it is normal and the patient has anginal symptoms, you will still admit the patient and record his ECGs after a after a few hours. Okay. Yes, Maithil, you can go for.
Yes, Shri. So I was talking about the concept of hibernating and stirred myocardium. It's a viable myocardium with impaired contractility, which occurs due to few reasons, like the stunned myocardium. It occurs post MI reperfusion, post PCI, and thrombolysis. It occurs in acute settings like acute ischemia. There is decreased function for few hours, and then the myocardium restores its ability. And hibernating myocardium occurs in chronic setting like chronic ischemia. There is decreased function due to low perfusion and persistent ischemic dysfunction. So it is very important to do FDG PET scan or MRI. FDG PET is more favorable. Then the theoretical part is next is types of MI. So there are 5 classes. Type 1 MI is atherothrombotic occlusion. Type 2 is the demand supply mismatch due to secondary to ischemia, due to seen in ICU patients, severe anemia, arrhythmia, and hypertension. Class 3 MI is uh, diagnosis of MI resulting in sudden cardiac death. Then class 4 MI is divided into two. A, post percutaneous after the PCI is done, and B is infarction from stent thrombosis. And type 5 MI is post coronary artery bypass graft. MI is developed. Next, this diagram is again the similar to the one we have discussed already. Presentation, the patient comes with pain, breathlessness, and according to the pain, then we do the ECG, and there is ST depression. In transmural MI, there is ST elevation, and then we do the cardiac markers, troponin, and diagnose it, the ACS classification. Next is NSTEMI. NSTEMI is partial occlusion, subendocardial ischemia. There is less extensive necrosis and early invasive uh, for treatment. So NSTEMI, incidence of NSTEMI is increasing due to burden of obesity, diabetes, CKD in aging population. Incidence of STEMI is declining due to greater use of aspirin, statin, less smoking. So NSTEMI is more common now. Pathophysiology of NSTEMI is due to imbalance between myocardial oxygen supply demand due to plaque fissure with inflammation, plaque fissure without inflammation, which leads to coronary artery thrombosis and plaque erosion. Next is on angiography. 10% may show left main artery stenosis. 35% may have 3 vessels coronary artery disease. 25% have 2 vessels. 20% have 1 vessel, and 1% have no apparent epicardial cardiac artery stenosis. So then we'll evaluate patient and take his history and do the physical examination. So we'll find chest discomfort severe with either occurrence at rest or minimal exertion for more than 10 minutes. Chest discomfort occur relative recent onset, like in less than 2 weeks, and if either it has a crescendo pattern, which is severe prolonged frequent chest pain. The chest pain is substernal region radiates to left arm, left shoulder, neck, and jaw. Anginal equivalents like dyspnea, epigastric discomfort, nausea, weakness may occur. More common in females, diabetes mellitus, and elderly patients. Do the physical examination to identify all the life-threatening diagnoses like pulmonary embolism, cardiac tamponade, and aortic dissection. Next, it's a very important table for NST-ACS. It's thrombolysis in myocardial infarction. So the risk markers are age more than 65 years. If it's a known coronary artery disease with more than equal to 50% of stenosis, ST elevation of more than 0.5 mm on presenting ECS, raised cardiac markers, more than equal to 2 original episodes in prior 24 hours, prior angina, or more than 3 coronary artery disease risk factor are present. So if we evaluate this risk markers and do the scoring. The scoring is between 0 to 2, then it's a low risk patient, and incidence of adverse cardiac events is 5 to 8%. If the scoring is between 3 to 4, it's intermediate risk patient, then the incidence of adverse cardiac events comes 13 to 20%. And if the score comes between 5 to 7, it's a high risk patient, and the incidence of adverse effect cardiac event is up to 40%. So next is the hard pathway for evaluation of acute chest pain. Patient comes with acute chest pain, we do the ECG, we see whether it's non-ischemic, ischemic, or STEMI. Non-ischemic patient is known the coronary artery disease is present or not. If no, then we'll do the hard score. What's a hard score?
Just
It
one
includes
question
history.
मुझे यहाँ पे पूछना था.
Yeah.
Yes.
हाँ.
So you have discussed the pathophysiology of the NST-ACS, और उसमें हमने ये discuss किया है. Even we have discussed in the topic of stable angina as well, that there is a presence of an atherosclerotic plaque in the vessels, and that plaque could be harmless, that most of the healthy individuals may have after the age of say 15 or 20 years. But what makes this plaque dangerous is the secondary pathophysiology which occurs on already on the existing plaque. Correct. उसमें क्या क्या हो सकता है आपने बताया ही है. प्लाक फिशर विथ इन्फ्लेमेशन, वे यहाँ पे इन्फ्लेमेटरी मीडिएटर्स आते हैं जैसे टी सेल्स, ये सब आते हैं. प्लाक फिशर विदाउट इन्फ्लेमेशन और एन इरोजन ऑफ द प्लाक, ऑल ऑफ दिस कैन लीड टू अ रप्चर्ड प्लाक, जहाँ पे हमने बोला था कि विद देयर विल बी अ कंप्लीट ऑक्लूजन ऑफ द वेसल लीडिंग टू एसटी एलिवेटेड एमआई, और देयर में बी एन इरोडेड प्लाक एज वेल. बट देयर इज वन मोर क्लासिफिकेशन ऑफ एमआई where, or a non-ST elevation MI where there is no occlusion actually happening. So what is that class? Can anyone answer? ऐसा कौन सा?
प्रिंजमेटल एंजाइना.
ओके, तो प्रिंज मेटल एंजाइना है जहाँ पे देर इज नो ऑक्लूजन, इवन इफ यू डू अ एंजियोग्राफी उसमें आपको कुछ भी ऑक्लूजन नहीं मिलेगा. द पैथोफिजियोलॉजी बिहाइंड दिस टाइप ऑफ एंजाइना इज ए कोरोनरी वैसोस्पाज्म. ठीक है. There are various causes of coronary vasospasm because of which this patient are highly susceptible to developing an MI. Here the treatment is nitrates and calcium channel blockers. Just for your information, again we will go talk about this later. ठीक है.
Yes. So hard score includes history, ECG, age, risk factor, and troponin. If hard score is 0 to 3, then serial troponins are done, and less than 99 percentile early discharge we do, and after serial more than 99 percentile cardiology consult and admission is preferred, and then stress testing and angiography is done, and uh, uh, less than 99% after initial troponin observation and admission is done. If the patient on ECG there is ST depression or T inversion present, ischemic changes is seen, then initial troponin is seen, and further evaluation is done. And if on ECG STEMI is seen, then the guidelines, STEMI guidelines are followed. The next table is also the similar kind, where the symptom onset, first medical contact, and ACS is diagnosed. We refer it to either to the PCI center or the non-PCI center. Like we evaluate the risk stratification, which is clinical. which in risk stratification is done based on clinical feature, TMI scoring, ECG biomarkers. Uh, there is gray scoring as well, which includes age, heart rate, systolic blood pressure, creatinine, and Philip class, and ST deviation. Uh, then uh, we, if the patient comes under the high risk, so we immediately transfer it to the PCI center, um, and immediate invasive therapy is done within 2 hours. If the patient is on high risk, then same day transfer is done, and early invasive in less than 24-hour therapy is suggested. If the patient comes under intermediate risk, then we transfer and do invasive therapy within 72 hours. And if the patient is low risk patient, transferring is optional, and non-invasive testing is more favorable. Next, yeah, cardiac. Coming to the cardiac markers, they are
So
elevated
basically,
because
yes, Maithili, I just wanted to break you a bit here. Basically, the point
yes,
यहाँ पे यही है कि what exactly is your center? If your center is like, say, a medical college, which is equipped with a PCI center, then you don't have to worry about much about anything. You just obviously take the patient. Procedure वही रहेगा. You have to take a proper history to look at all the risk factors, whether the patient is hypertensive or diabetic. Look at his vitals. If he is in shock or has pulmonary edema or has any arrhythmia, do an ECG first of all within 10 minutes. Diagnose the patient on the basis of ECG whether he is having a ST elevation MI or a non-ST elevation but an acute coronary syndrome. Then you can decide if your center is equipped with PCI, you should go take the patients directly for PCI. If your center is not having PCI, then you should do thrombolysis if it is a STEMI. Otherwise, stabilize the patient first, giving anticoagulation and managing all the complications depending on the complication. जैसे कि अगर pulmonary edema होगा, then you'll have to use non-invasive ventilation or BiPAP support, give diuretics, and give inotropes if the patient is in shock. Stabilize the patient, wait for the cardiologist to come. Uh, if it does not happen, that your center is not equipped with PCR, then you can refer the patient, but only after stabilization and depending on the risk factors. So all these scores are important, but basic clinical picture जो है कि history आप लेते हो, ECG करते हो, and then doing a troponin, looking for the serial rise in troponin. All this actually is the cornerstone of management of a acute coronary syndrome.
yes. So there are various reasons why the cardiac troponin values are elevated in myocardial injuries, like myocardial injury related to acute myocardial infarction, like atherosclerotic plaque disruption or erosion. Second is myocardial injury related to acute myocardial ischemia due to reduced myocardial perfusion, coronary artery spasm, microvascular dysfunction, coronary embolism, coronary artery dissection, and respiratory failure, severe anemia. Other reasons can be cardiac conditions like heart failure, myocarditis, cardiomyopathy, any type, Takotsubo syndrome, and systemic condition like sepsis, CKD, stroke, subarachnoid hemorrhage, pulmonary embolism, and inflammatory diseases like amyloidosis, sarcoidosis. So they causes elevation of cardiac troponin values um, due to troponin complex bound actin filament uh, uh, coming into the blood circulation. So
So इसका क्या importance हो सकता है? Practical importance क्या हो सकता है इसका?
यही कि CKMB और ये सब तो वेरियस सेटअप्स में इंक्रीज हो सकते हैं, बट
Even troponins can increase. ये इसका point है.
हाँ,
Troponin, just a rise in troponin without knowing the history or an ECG picture, you will not be able to say कि the troponin rise is only because of a myocardial infarction. तो ये गलती
इंफेक्शन।
कई बार हो जाता है कि आप सिर्फ रिपोर्ट देखते हो और a doctor on duty just sees the report that the troponin is say rise like has risen above like 10 times or 20 times and then calls up the senior and says कि sir कि ये तो MI लग रहा है and you are going to thrombolize. But it turns out that the patient has a chronic kidney disease where the troponins will be naturally high. or the patient has
Yes.
sepsis, or the patient has a stroke. So initially, always you have to take the history. If the history is very much suggestive of angina or anginal equivalent, then only the ECG and the cardiac troponins come into the picture. In context of ACS, I am saying, okay, troponin rise is important in various other settings जो यहाँ पे पूरे आपने गिना दिए कि सीवियर एनीमिया हो सकता है, हार्ट
Hmm.
फेलियर में हो सकता है, कार्डियोमायोपैथी हो सकता है, एक्सेट्रा. बट अगर आपको पेशेंट acute coronary syndrome के हिसाब से मैनेज करना है, then the context of troponin is important if the patient has a history of angina or any anginal equivalent and the patient has ECG changes, then the troponin level becomes very important to diagnose if it is acute coronary syndrome, and then you can proceed with the management of acute coronary syndrome. In case the troponin rises due to any other condition, then you will have to manage that condition first and then do certain other investigations to determine if the patient has a coexisting cardiac problem as well. जैसे कि सीकेडी पेशेंट में अगर कंसिस्टेंटली आपको ट्रोपोनिन बढ़ा हुआ मिलता है, तो इट इज पॉसिबल दैट बिकॉज ऑफ वॉल्यूम ओवरलोड इवन द हार्ट इज इन्वॉल्व सेकेंडरीली. Then you have to do a 2D echocardiography to see whether if the heart is also involved, there is global hypokinesia or dilated cardiomyopathy, etc. या फिर पेशेंट को सेप्सिस है तो आपको सेप्सिस के हिसाब से you'll have to manage it कि there can be secondary cardiac involvement in sepsis as well, which is known as septic cardiomyopathy. ठीक है. तो ऐसे अलग अलग कंडीशंस में सिर्फ ट्रोपोनिन के वैल्यूज देख के यू कैन नॉट से इफ इट इज एन एक्यूट कोरोनरी सिंड्रोम. यू हैव टू सी इट विद इन द कंटेक्स्ट ऑफ द हिस्ट्री एंड एग्जामिनेशन एज वेल एज द ईसीजी चेंजेस. ठीक है.
यस यस, तो ये नॉन स्पेसिफिक है ऐसा, तो सब कुछ ही लेना पड़ता है. Next, we'll go with the STEMI part, then we'll do the treatment part. So, STEMI is acute total occlusion due to plaque rupture in the left anterior descending artery or right coronary artery or the left circumflex artery. So, there is total occlusion of the lumen, and coronary blood flow decreases abruptly after the thrombotic occlusion of previously affected coronary artery by atherosclerosis due to vascular injury like smoking, hypertension, and various other factors. And a mural thrombosis is formed, which in which the platelet monolayer is formed and causes vasoconstriction because it is adhesive due to presence of fibrinogen and integrin, which causes activation of coagulation cascade and factor 8 and 10 activation, which causes fibrin activation and platelet cross-linking occurs. Then there is role of acute plaque rupture and erosion, as I've already explained in previous slides. So patient comes with clinical features and which gets aggravated on exercise stress and uh, other illnesses. Pain can be heavy, squeezing, crushing type, crushing, stabbing, and burning type. It can be present at rest. Earlier, we have seen unstable angina and STEMI. At rest, it was not at much seen. The STEMI is seen at rest, severe for a long time, associated with sweating, nausea, vomiting, anxiety, and it is located beneath the xiphoid epigastrium and radiates as high as occiput but not below the umbilicus. And pain can stimulate from acute pericarditis, and pain can stimulate the pain from acute pericarditis, pulmonary embolism, costochondritis, or GI disorder. So they are also potential differential diagnosis of STEMI. Then findings on examination, we can find the patient can be anxious, restless, uh, alter their positions. They might stretch the decubitus position. So failure can be associated with perspiration and cool extremities. The combination of chest pain for more than 30 minutes plus diaphoresis is highly suggestive of STEMI. Nor the on vitals, on examining vitals can be normal, BP and heart rate in the first hour, to the sympathetic hyperactivity and inferior infarction presence in the later hours, and parasympathetic hyperactivity in the further time. Left ventricular dysfunction can be present, ST and S4 can be heard, increase in S1 and S2 splitting can be observed. Uh, Transmid-diastolic or late systolic murmur can also be heard, and decrease in carotid pulse and stroke volume can also be present. Uh, Vulnerable plaque and thrombogenic blood I have explained earlier only. So yeah. Next we do the investigation. In ECG, reciprocal changes may be observed and significant elevation in V2, V3 may be present like more than 2.5 mm of ST elevation in less than 40 years is significant. More than 2 mm in more than 40 years and more than 1.5 mm of elevation in a female. And then we'll do the cardiac marker and 2D echo.
I just wanted to add one thing. Uh, you said in the ECG that reciprocal changes may be present, but to diagnose
Yes.
MI, both of the things are important. If the changes of ST elevation are present in the contiguous leads, like in inferior lead would be 2-3 AVF and lateral would be 1 AVL V5 V6. Only elevation in the contiguous leads is not important. You should have at the same time reciprocal changes to be present to have to be absolutely sure that it is a ST elevation MI. Okay.
Oh,
And
okay, okay,
the measurement that you have given is absolutely correct कि उतना elevation होना चाहिए. But at times, characteristic morphology of ST elevation will give a clue, and the patient examination and history would give a clue. Then you can straight away take the patient for thrombolysis after
okay.
sending
Both
the
the
troponins.
parameters should be fulfilled.
It is important,
Reciprocal
yes,
changes,
yes.
yes.
हाँ.
So,
And most of
no,
sometimes you may there will be changes in the cardiac portion which is not displayed in your 12 lead ECG. कैसे? जैसे कि posterior wall है. Posterior wall का myocardial infarction directly ST elevation करके present नहीं करता है. That time you should have a strong clinical suspicion that the patient can have MI. In that, very specific changes are there in the 12 lead ECG also. But for confirmation, you have to do certain modification of the ECG. Like you have to do a posterior wall ECG, जिसमें आपका जो anteriorly leads आप लगाते हो V4, V5, V6, वही leads आप posteriorly लगाते हो. ठीक है. तो उसमें फिर आपको V7, V8, V9 करके leads मिलेगा. That is basically V4, V5, V6, but attached posteriorly. वहां पे आपको इवन 1 mm का एलिवेशन अगर मिल जाता है, that is diagnostic of posterior wall MI. So localization of MI on the basis of ECG is a completely different topic and a big topic by itself. But I'm just saying that sometimes the MI may be missed because of these scenarios. Like even RVMI, that is right ventricular MI, is not visible very well on the 12 lead ECG as ST elevation. There are different other changes, but ST elevation शायद नहीं मिलेगा. तो in that case you have to be very alert, like that could be an MI. तो आपको उस हिसाब से you have to take a right ECG, है ना, right ECG leads लगाने पड़ेंगे या posteriorly आपको posterior leads लगाने पड़ेंगे. Then you can find certain changes. Even AVR elevation is very significant of a very proximal obstruction. तो ये सारे थोड़े modifications है. Otherwise what you have said is completely true.
yes, okay. Uh, Coming to the management part, uh, the golden hour for STEMI management is the first 6 hours of the onset of the chest pain, because only 1/6 of the myocardium remains viable. Then pre-hospital care is very important because that occurs in the STEMI patient due to ventricular fibrillation within the 24 hours, and most commonly in the first hour itself. So the recognition of symptoms is very important. Then development of emergency medical team, transportation of patient is important, and reperfusion is important. If the patient is in remote area, the fibrinolytic treatment should be started. So, by the European Society of Cardiology, the target time in STEMI, if the patient develops chest pain, the first medical contact should be uh, done, and the staff should take and interpret the ECG and use defib in less than 10 minutes. The diagnosis should be made, and with if a 24-hour PCI center, as she has mentioned, is available, then diagnosed to wire crossing time should be within 1 hour. And if PCI center is not available, then shift the patient to the center within 120 minutes, and wire crossing should be done within 90 minutes. And if we can't reach the PCI centers, then thrombolysis should be done with tenecteplase or retiplase, and we should try we should assess the patient and try if if he needs PCI, then we should transfer it to the PCI center and check for the ST resolution after 60 to 90 minutes after the thrombolysis. And if 70% uh, of the plaque is resolved, then initial thrombolysis and pharmacoinvasive approach should be done. And if it's not resolved, if it's less than 70%, then it's unsuccessful, and we should rescue PCI, do the rescue PCI or emergency PCI. So next is what is thrombolysis? So thrombolysis includes the uh, the drugs like streptokinase, tenetoplase, retiplase, and altiplase. They are fibrin specific, and the streptokinase is not fibrin specific, but tenetoplase and retiplase are fibrin specific. They are given as a tenetoplase are given as a bolus dose of 15 mg, followed by 15 mg bolus is given, followed by a 50 mg intravenous in the first 30 minutes and 35 mg of intravenous in the next 60 minutes. And retiplase and altiplase are fibrin specific. They have 80% and 75% potency respectively, given as 10, the retiplase is given as 10 million unit uh, in the first 2 to 3 minutes, followed by 10 million units in the next 30 minutes. And the streptokinase, which is fibrin non-specific, is given with it has potency of 50% as 1.5 million units intravenous in the first hour.
So reperfusion के लिए जो drugs देते हैं that are known as the fibrinolytics, only issue is with the cost. Okay, so streptokinase obviously is a older drug, time and tested drug, so it comes at a very less cost. So most of the centers still have streptokinase. Even in Sevagram we do thrombolysis with streptokinase most of the times. Retiplase and tenecteplase are a bit costly. Recently Ayushman Bharat schemes are available for tenecteplase. So probably in days to come, we'll be trying to shift the patients for thrombolysis on tenecteplase. Tenecteplase and retiplase में advantage ये है कि they are fibrin specific. The adverse effects of streptokinase majorly initial part में hypotension है और anaphylaxis है. So you have to continue monitoring the patient when the streptokinase is given, and that is around for 1 hour. So you have to take BP continuously every 5 minutes or 10 minutes. Sometimes you need ionotropic support just to complete the thrombolysis. These factors are not so much prevalent in doing thrombolysis with retiplase and tenecteplase. Another thing is repeat MI आने के बाद भी you can give fibrin specific drugs, but it is not the case with streptokinase because the patient will have developed antibodies. So he can develop reaction against streptokinase if it is given again. For every thrombolysis, we have to see for the indications and the contraindications. So there are absolute contraindications to thrombolysis, and there are some relative contraindications. Most of the centers will have no other options to thrombolize the patient, but in those cases, you have to give clear you take a written informed consent from the relatives of the patient that the fibrinolytic therapy is life saving, but there are certain contraindications and certain side effects of it, and you have to explain in detail before initiating thrombolysis. Okay, these
Yes.
are the things that you will see when you are doing internship. For the final year students, if there are some interns already here, try to focus on how these things happen in your hospital settings. Uh, I don't know if Silvassa is a PCI enabled center. In case it is not, then definitely fibrinolysis आपके उधर बहुत regularly होता होगा. So whenever you go to the मतलब for even other medical students as well, अगर आप cath lab में ड्यूटी करते हो, this is something you should note कि क्या प्रोसीजर exactly शुरू है.
Yes. The clear contraindication of fibrinolytic therapy can be are the cerebrovascular hemorrhages, non-hemorrhagic stroke, cerebrovascular event in past 1 year, severe hypertensive like systolic is more than 180 and diastolic BP is more than 110, or there is any active internal bleeding, or head and spine injury surgery done within 3 months. And the relative contraindications, we use the fibrinolytic therapy by assessing the risk benefit ratio. Uh, it includes allergy and severe controlled hypertension, active peptic ulcer disease, hemorrhagic ophthalmic conditions like diabetic retinopathy, etc., and pregnancy. Next is the complication of STEMI. Complication is divided into electrical complication and mechanical complication. Electrical complication is due to the instability in the ischemic myocardium. It occurs within minutes to days, 1 day, and it includes the most common cause of sudden cardiac death in STEMI is ventricular fibrillation. Second is ventricular tachycardia. Third is sinus bradycardia. Then AV block. Then bundle branch block and atrial fibrillation. These are the electrical complications of STEMI. Mechanical complications occurs in 3 to 7 days after MI due to myocardial necrosis. They are ventricular septal rupture, rupture of the ventricular free wall, papillary muscle rupture, ventricular aneurysm, pump failure, ischemia, or any inflammatory complication like early pericarditis and Dressler syndrome. So, ventricular septal rupture incidence is 0.2 to 3% without reperfusion therapy, and it has a bimodal peak. It can occur within 24 hours and 3 to 5 days. Manifest as chest pain, shortness of breath, and hypotension. On physical finding, hollow systolic murmur and thrill and S2 is heard, and echocardiography. Ventricular septal rupture is seen left to right shunt on color flow Doppler echocardiography through the ventricular septum, and pattern of RV overload is seen. Next complication is rupture of the ventricular free wall, which occurs in 0.3 to 1% of the patient. In fibrinolytic therapy does not reduces its risk, and primary PCI seems to reduce its risk. It also has a bimodal peak within 24 hours and 3 to 5 days. Range is 1 to 14 days. Clinical manifestation, it manifests as anginal, pleuritic, or pericardial chest pain with syncope, hypotension, or restless and sudden death. On physical finding, JVP is distended in approximately
मैं
29.
एक यहाँ पे ऐड करता हूँ
Yes.
मैथिली. सो इसमें व्हाई इज इट इम्पोर्टेंट टू डिस्कस कॉम्प्लिकेशंस, ये इसके बारे में बोलते हो. व्हाट हैपेंस प्रैक्टिकली इज व्हेन यू have a patient, you take the history, you see that the anginal symptoms are present, you do a ECG, you prove that it's a STEMI, let us say it is anterior wall ST related myocardial infarction, you thrombolize the patient, the ST elevation settles down a bit, angina is reduced, patient is now very much comfortable, ठीक है, and you are waiting for the cardiologist to come so that you can take him for the PCI. But क्या हो रहा है कि 2 to 3 days बाद you repeatedly assess the patient every day. You ask him whether he has a chest pain. आपको कुछ और symptoms है क्या? The patient says he is all okay. But 2 to 3 days after, sometimes you would say कि breathlessness हो रहा है, chest pain recurrent हो रहा है. You may feel that it is just recurrent angina and you just step on the anti-anginal drugs. Yeah, this mistake can happen, but you have to be very alert of this all complications of especially the ST elevation MI. ठीक है, तो ऐसे कॉम्प्लिकेशंस हो सकते हैं. दैट इज व्हाई इट इज इंपॉर्टेंट टू डू अ प्रॉपर एग्जामिनेशन ऑफ द पेशेंट who has already been thrombolized. He can develop a ventricular septal rupture. The classical telltale finding here is a systolic murmur in the harsh holosystolic murmur. You can have the patient who going into a pulmonary edema as well. ठीक है, rupture of the ventricular free wall is also possible when the patient can go into a shock. ठीक है, it could be a cardiogenic shock, but the cause is here ventricular free wall. In both all these cases, it is the CVTS surgery which has to be performed. But however, you have to first stabilize the patient as well. ठीक है, and you have to be alert to all these complications. That is what is important. So you cannot discharge the patient immediately after developing a STEMI and thrombolizing, saying that कि उसका angina तो खत्म हो गया and you just have to put on the medical treatment, because you have to keep him in hospital because to see for whether he develops all these mechanical complication as well as his ECG complications. Like all these ECG complications, like arrhythmia complications, are most of the times they will settle after thrombolysis, but sometimes they will be persistent. Like in inferior wall MI, the patients can develop various types of blocks क्योंकि RCA जो है, right coronary artery, supplies your conducting system of the heart. तो आरसीए इन्वॉल्वमेंट के कारण कई बार बहुत सारे अलग अलग ब्लॉक आ सकते हैं, जैसे कि कंप्लीट हार्ट ब्लॉक, ये सब आ सकता है. After thrombolysis, it may get settled down, but sometimes it may not get settled down. In that case, you'll have to give a temporary pacemaker and then resolve the clot in the RCA and wait for the changes to settle down and wait for the arrhythmia to settle down. ठीक है. तो ये सब reasons के वजह से you will have to keep the patient after thrombolysis as well in the hospital and monitor them rigorously every day, whether the heart rate is okay, the BP is normal, the patient does not have any additional symptom, how have the symptoms improved over the last day. Everything you have to ask whenever you go for the rounds for these patients. Okay.
Yes. Thank you, Shri. Next is the papillary muscle rupture. Uh, it also manifests as abrupt onset of shortness of breath, pulmonary edema, or hypotension. And on findings, we find a soft murmur in some cases, and there are no thrills. Variable signs of RV overload and severe pulmonary edema and cardiogenic shock may be present, as she mentioned. And ECG findings can be hypercontractile LV, torn papillary muscle, or chorda tendini, and severe mitral regurgitation on color flow Doppler can be seen. And next is ventricular aneurysm, which may present as heart failure or arrhythmias. And pump failure can be presented like cardiogenic shock. And next is ischemia, which present as recurrent angina or infarction. And inflammatory changes are seen after months, like Dressler syndrome, which is an autoimmune pericarditis with pericardial effusion, and early pericarditis presenting as sharp pleuritic chest pain and pericardial friction rub. So, Shri, now should I go with the treatment part of unstable angina and IHD
Yes,
everything?
yes, yes. अभी मेडिकल मैनेजमेंट की बात करते. We have talked extensively about stable angina and non-ST elevation ACS as well as ST elevation ACS. We have talked in brief about thrombolysis as well and the complications that may develop after ST elevation MI. Please remember, for people who are giving university examination, it could be a short note on each of the complications, or it could be a long portion on ST elevation MI. You have to read something more from the textbooks as well, but we have tried to cover most of the points. Okay. Now here we are talking about the imaging and the medication part.
Yes, thank you. Okay. Now, we will be discussing the management of ischemic heart diseases. First, we will take the history and do the physical examination, run the routine laboratory investigations like urine, blood examinations, for urine for diabetes mellitus and renal diseases, blood for lipid profile, glucose, creat, hematocrit, and CRP levels. Chest X-ray is done to rule out any complications, cardiac enlargement, ventricular aneurysm, etc. And ECG is done. Then it's not commonly practiced this stress testing, which is recorded before, during, or after exercise. And because mostly the patient comes in the emergency settings, and when we run the ECG, ST changes are seen. So stress testing is not used that much. Um, in stress, if the resting ECG is normal and after the exercise there is ST segment depression or segment elevation, then it's a positive stress test. It is contraindicated in acute MI, unstable angina, arrhythmia, severe aortic stenosis, or acute pulmonary embolism or pericarditis. And relative contraindications are electrolyte abnormalities, severe hypertension, bradycardia, or bradyarrhythmia or tachyarrhythmia, or cardiomyopathy or AV block. Then we do the cardiac imaging. When the resting ECG is abnormal, more than 1 mm of ST segment depression or ST elevation or dynamic STT changes are seen, then we do the cardiac arteriography. Whose indications are patient with chronic stable angina, who are severely symptomatic despite of the medical therapy. There are troublesome symptoms in the presenting diagnostic difficulty. If the patient is a known case of or a suggestive case of angina who survived a cardiac arrest, or a patient with angina or evidence of ischemia is present, if the patient or the patient having a chest discomfort suggestive of angina but negative or non-diagnostic stress test, or a patient with a career involving a safety for safety of others like a pilot or a firefighter or a police. In them we do the cardiac imaging. So prognostic factors for IHD are age, functional state of left ventricle location, and the coronary artery narrowing. And the poor prognostic factors are recent angina, unstable angina, congestive heart failure, unresponsive angina, pulmonary edema, transient S3, MR, cardiac enlargement, or the or reduced ejection factor. So treatment, coming to the treatment part. Once we have diagnosed ISD, the management plan includes explanation of the problem and reassurance about the treatment ability. We must reassure the patient that it's not the end, like it is a treatable disease, and we should tell जो भी हमने स्टडीज में पढ़ा है कि इसका ट्रीटमेंट से ठीक हो जाते हैं। फिर हमको आइडेंटिफाई करना है एग्रीवेटिंग कंडीशंस को, तो उसके लिए हम जैसे कि थायराइड प्रोफाइल करवा सकते हैं और उसको भी ट्रीट करना है, रिकमेंडिंग एडेप्टेशन ऑफ एक्टिविटी एज नीडेड। तो अ, जैसे कि हमको पता है कि आईएसडी में मायोकार्डियल ऑक्सीजन डिमांड सप्लाई का मिसमैच होता है, तो उसके वजह से हम लोग को मेटाबॉलिक इक्विवेलेंट टास्क जो होता है उसके अकॉर्डिंग पेशेंट को बोलने का है कि इतना काम करना है, इतना काम नहीं करना है, तो वो हम लोग ये मेट स्कोर से डिसाइड करते हैं। जैसे कि वॉशिंग और शेविंग, ड्रेसिंग। मेट स्कोर क्या है कि एक मेट जो है वो डिनोट करता है 3.5 ml ऑफ ऑक्सीजन पर केजी पर मिनट। तो अगर पेशेंट का मेट स्कोर 7 to 10 आ रहा है, तो फिर उसका स्ट्रेनस एक्टिविटी पे अंजाइना आ रहा है, या तो 4 to 7 मेट स्कोर आ रहा है तो अंजाइना विथ मॉडरेट एक्टिविटी आ रहा है, और स्कोर लेस देन 4 आ रहा है तो मिनिमल एक्टिविटी पे भी उसका मेट स्कोर सॉरी अंजाइना आ रहा है। तो ये हमको असेस करना है और उसके अकॉर्डिंग ही उसको अपना लाइफस्टाइल अडॉप्ट करने को बोलने का है। फिर ट्रीटमेंट ऑफ द रिस्क फैक्टर टू प्रिवेंट एडवर्स कोरोनरी आउटकम, लाइक ट्रीटिंग हाइपरटेंशन, डायबिटीज mellitus and dyslipidemia, then ड्रग थेरेपी फॉर एंजाइना एंड कंसिडरेशन ऑफ रिवेस्कुलराइजेशन। तो ये पूरा उसका मैनेजमेंट प्लान होता है आईएसडी को ट्रीट करने का। Lifestyle modification, we will ask patient to stop smoking, reduce and maintain an ideal body weight to keep physical exercise and avoid walking or exercise after heavy meal, and take the sublingual nitrate. Heavy diet, 2 to 3 serving of oily fish per week. Healthy diet should be recommended, which is 2 to 3 serving of oily fish uh, per week. And saturated fatty acid should be lower down to less than 10%, and limit the salt intake less than 5 gram per day, and fiber to 30 to 45 gram per day, and limit alcohol consumption. Coming to the drug therapy, uh, it includes nitrates, beta blocker, calcium channel blocker, potassium channel openers, and other second line management, um, like potassium channel activators, IF channel antagonist, antiplatelet drugs, statins, rho kinase, and ACE inhibitor and ARVs when the comorbidities are present. So nitrates. Um, Nitrates acts by the action of vasodilating the coronary arteries, and decreasing the venous return and preload and afterload of the uh, myocardium. So nitrates are used as prophylactic and for the treatment part of angina. Uh, they are contraindicated when the patient is on PD, phosphodiesterase 5 inhibitor like sildenafil or tadalafil, because it can cause severe hypotension. And they are present as various preparation like glycerol trinitrate, isosorbate dinitrate, isosorbate mononitrate. Um Nitrates are given for acute relief of angina, like sublingual glycerol trinitrate, and long-term prophylaxis, oral isosorbate mononitrate or oral isosorbate dinitrates, and they are usually added with beta blockers and calcium channel blockers when the beta blockers and calcium channel blockers are not tolerated. Then long-acting nitrates are given. So short-acting and long-acting nitrates have common side effects of uh, headache, flushing, hypotension, syncope, postural hypotension, reflex tachycardia, and methemoglobinemia due to their property of producing vasodilation. And reflex tachycardia is due to hypotension and postural hypotension it is producing, and they're contraindicated in PDA5 inhibitors when patient is PDA5 inhibitor, or or the patient is has hypertrophic obstructive cardiomyopathy. Then these are the various preparations like ointment. The nitroglycerin NTG is present as uh, ointment, transdermal patch, sublingual tablet or spray. Isosorbate dinitrate is present as oral and oral sustained release, and isosorbate 5 mononitrate can be present as oral and oral sustained release tablets. Doses of nitroglycerin sublingual tablet is zero point 0.3 to zero point 0.6 mg, and it is scheduled as needed, and up to 3
मैं
doses
मैथिली
5
थोड़ा
minutes.
पॉज करता हूँ मैं एक बार बस।
Yes.
इसमें हम थोड़ा सा ब्रॉडली देखते हैं बिकॉज इन रिमेम्बरिंग इंडिविजुअल ड्रग वुड बी वेरी डिफिकल्ट। तो एज अ क्लास हमने नाइट्रेट्स के बारे में डिटेल में डिस्कस किया है। एक ही पॉइंट मुझे ऐड करना है कि इफ द पेशेंट इज रिक्वायरिंग मोर एंटी एंजाइनल रिलीफ यूजिंग नाइट्रेट्स, लाइक ही इज सेइंग कि मुझे सबलिंगुअल नाइट्रेट पहले 2 बार ही लेना पड़ता था, अभी 3 से 4 बार लेना पड़ रहा है, that means he is not doing very good on anti-anginal drugs and he might be developing a new plaque or let us say a new angina which will need further evaluation। ठीक है, तो ऐसे कभी नहीं करना है कि कोई पेशेंट अंजाइना के साथ आ रहा है तो यू जस्ट कीप ऑन गिविंग nitrates, maybe a longer acting nitrates or a longer acting nitrate or other forms of nitrate। ऐसा नहीं करना है। You have to first evaluate whether the angina that is developing is because of a and because of a clot in a different artery or is it related to the same disease। तो अगर वो सेम डिसीज से रिलेटेड है तो इंस्टेड ऑफ इंक्रीजिंग द डोज ऑफ nitrate you will have to think about adding on the other drugs for angina like beta blocker or CCB। ठीक है। Also we have to remember that all of these drugs have a tendency to decrease blood pressure। So आपको blood pressure पे हमेशा ध्यान देना है and you have to look at the side effects as well कि headache हो रहा है क्या, tachycardia हो रहा है क्या, postural hypertension हो रहा है क्या। You cannot just keep on giving drugs for angina if the patient develops all these side effects। You will have to think of managing the side effects as well as managing the angina। If the patient has persistent angina despite giving all these drugs, then again that becomes an indication of cardiac imaging। ठीक है। We
Yes.
can go to beta blocker list and we can
Yes.
cover the other forms in very short। मतलब तुम क्लास के बारे में you can just say and then
हाँ.
because each individual drug will have its own variation।
Yes. तो बीटा ब्लॉकर्स जो है वो B1 ऐसे सिलेक्टिविटी पे काम करता है, तो बीटा 1 रिसेप्टर्स होते हैं जो कि बीपी को कम करते हैं, हार्ट रेट को कम करते हैं, माइकार्डियल कॉन्ट्रैक्टिलिटी को कम करते हैं। और कार्डियो सिलेक्टिव, नॉन कार्डियो सिलेक्टिव बीटा ब्लॉकर्स होते हैं। कार्डियो सिलेक्टिव में मीटोप्रोलोल और बिसोप्रोलोल और एटेनोलोल आते हैं। मीटोप्रोलोल इज गिवन 50 टू 200 mg ओडी डोज। फिर नेक्स्ट है कैल्शियम चैनल ब्लॉकर्स जो कि मायोकार्डियल डिमांड को कम करता है बाय कोरोनरी वासोडाइलेशन। तो ये भी कॉन्ट्रैक्टिलिटी को कम करता है और बीपी को कम करता है। सीसीबी हम जब बीटा ब्लॉकर्स कॉन्ट्राइंडिकेटेड है तब देते हैं, और वाइजोस्पास्टिक अंजाइना में ये हम यूज करते हैं उसका ट्रीटमेंट पार्ट में। और इसका नेगेटिव आयोनोट्रोपिक एक्शन भी है जिसके वजह से एलवीएफ को ये एग्रीवेट करता है, तो उसमें भी हमको ध्यान से इसको यूज करना है। इसमें डाइहाइड्रोपायरिडिन्स और नॉन डाइहाइड्रोपायरिडिन्स आते हैं जैसे कि एम्लोडिपिन। डीएचपीज में एम्लोडिपिन, फेलोडिपिन और नॉन डाइहाइड्रोपायरिडिन्स में डिल्टियाज़िम और वेराप्रिमिल्स। तो चॉइस कैसे करेंगे? तो बीटा ब्लॉकर ज़्यादा हम प्रिफर करते हैं, क्योंकि उसका स्टडीज ने शो किया कि वो लाइफ एक्सपेक्टेंसी को ज़्यादा इम्प्रूव करता है। और सीसीबी को हम तब यूज़ करते हैं जब वही बीटा ब्लॉकर हम यूज़ नहीं कर सकते, जैसे कि अस्थमा हो गया, और नाइट्रेट्स के साथ हमको ऐड करना है जब यूज़ करना है, और अंजाइना and history of asthma, COPD, sick sinus syndrome, vasospastic angina, symptomatic peripheral artery disease है, तब CCBs are more indicated. Next is potassium channel activator, which has nicorandil as a drug, and uh, IVF channel antagonist, ivabradine, जो कि ब्रेडिकार्डिया करवाता है, और एंटीप्लेटलेट ड्रग्स होता है जैसे कि एस्पिरिन, और P2Y12 एंटागोनिस्ट क्लोपिडोग्रेल, जिसको 75 to 150 mg पर डे के डोज में यूज किया जाता है, जो वाजो कंस्ट्रिक्शन इनहिबिट करता है बाय थ्रोम्बोक्सिन A2 इनहिबिशन, और टेटिन रोकाइनेस इनहिबिशन एंड एस इनहिबिटर एंड ARBs are used when the comorbidities are present. Now coming to the coronary revascularization part, which has aimed to restore the myocardial perfusion using percutaneous interventions and coronary artery bypass grafting. PCI for less extensive diseases and CABG is used for superior long-term outcome. Coronary revascularization supplements the medical therapy. It does not replaces it. तो मेडिकल थेरेपी के बाद ही हम पीसीआई या कैबजी करते हैं। तो पीसीआई में हम स्टेंट डालते हैं जो कि लीजन पे ही सीधा उसका एम होता है, और कैबजी में हम ग्राफ्ट करते हैं जो कि लीजन के आगे भी पूरा का पूरा कल्प्रिट लीजन के आगे भी वो ठीक करता है। तो ये हम तब करते हैं जब अंजाइना प्रेजेंट होता है ड्रग्स देने के बाद भी, और स्टेमी एंड स्टेमी अनस्टेबल अंजाइना ये प्रेजेंट है, या तो डायबिटीज मेलाइटिस विद मल्टीवेसल कोरोनरी आर्टरी डिजीज है, तब हम रिवास्कुलराइजेशन करने का प्लान करते हैं। तो पीसीआई में एंजियोप्लास्टी विद स्टेंटिंग इज डन, which relieves angina in more than 95% of the patient and restores the blood flow to the myocardium and improves the chest pain. So, percutaneous transluminal coronary angioplasty is done via the femoral radial brachial artery. Balloon is inflated to dilate the stenosis area. So, ये डायग्राम है जिसमें बलून को इन्फ्लेट करके हमने ल्यूमेन का साइज फिर से रिस्टोर कर लिया है। देर आर टू टाइप्स ऑफ स्टेंट, बेयर मेटल स्टेंट्स जो अभी ज्यादा यूज नहीं होते, और ड्रग एल्यूटिंग स्टेंट्स अभी ज्यादा यूज हो रहे हैं क्योंकि वो एंटीप्लेटलेट ड्रग्स रिलीज करते हैं, और दे डिलेज द एंडोथेलियल हीलिंग, वेसल बिकम स्टेबल, तो उसमें थोड़ा सा सब एक्यूट या लेट स्टेंट थ्रोम्बोसिस का रिस्क होता है, जिसके वजह से अक्यूट एमआई या सडन डेथ हो सकता है ड्रग एल्यूटिंग स्टेंट्स में। तो उसको प्रिवेंट करने के लिए हम डुअल एंटीप्लेटलेट थेरेपी पे पेशेंट को रखते हैं। एस्पिरिन और स्टेटिन देते हैं 2 साल तक, और एस्पिरिन 1 साल तक देते हैं। टेक्स्ट बुक में तो लाइफ लॉन्ग एस्पिरिन का लिखा था कि हम
एस्प्रिन और
एस्पिरिन।
क्लोपिडोग्रेल तुम शायद बोलना चाहते थे, वो गलती से स्टैटिन बोला।
सॉरी।
सो एस्प्रिन
हाँ।
प्लस क्लोपिडोग्रेल, बट अभी क्लोपिडोग्रेल के क्लास में तीन और ड्रग्स है, उसके बारे में मैं शॉर्ट में मेंशन कर देता हूँ। प्रेसुग्रेल है, टिकाग्रेलोर है, और
हम्म।
क्लोपिडोग्रेल है। तो ये तीन ड्रग्स है। यूजुअली अगर आपको पोस्ट इंटरवेंशन अगर बात करेंगे तो मोस्ट ऑफ द कार्डियोलॉजिस्ट गो फॉर ए टिकाग्रेलोर, ठीक है। बट prasugrel is also effective. Ticagrelor is almost effective होता है. Clopidogrel will be given if the patient only has underwent a medical management, and it can be continued for let us say for 1 hour 1 year, and you can discontinue the clopidogrel or ticagrelor or whatever and just continue with the aspirin part. ठीक है.
एस्पिरिन।
If the patient develops side effects with aspirin, you can very well replace aspirin by another antiplatelet agent like clopidogrel. ठीक है. एस्पिरिन से कई बार पेशेंट को गैस्ट्राइटिस, डिस्पेप्सिया जैसे सिम्टम्स आने लग जाते हैं, तो यू कैन शिफ्ट टू क्लोपिडोग्रेल और टिकाग्रेल और एजो। प्रसुग्रेल इसमें एक स्पेसिफिक है, एजेड पेशेंट में आप प्रसुग्रेल अवॉइड करोगे, ठीक है, उसमें अबव द एज ऑफ 60 years। एंड क्लोपिडोग्रेल के अलावा जो भी एंटीकोएगुलेशन, सॉरी, इंक्लूडिंग क्लोपिडोग्रेल, प्रेसिग्रेल एज वेल एज टिकाग्रेल हैव इंक्रीज ब्लीडिंग टेंडेंसीज। तो आपको कोई भी पेशेंट जिसमें ब्लीडिंग का रिस्क हो, उसमें आपको बहुत ध्यान से ये ड्रग्स देना है।
यस।
स्टैटिन हैज टू बी, स्टैटिन हैज टू बी कंटिन्यूड फॉर लाइफ लॉन्ग फॉर मोस्ट ऑफ द पेशेंट, बिकॉज यहाँ पे एलडीएल टारगेट जो होते हैं पोस्ट एमआई पेशेंट्स
True.
में, ये बहुत ही स्ट्रिक्ट होता है। इसलिए आपको स्टैटिन, आपको हाई डोज स्टैटिन डिपेंडिंग ऑन द ट्यूम थ्रोम्बाई लोड, या फिर मतलब जिस तरह से थ्रोम्बस का मतलब का आर्टरी का जो एनाटॉमी था जहाँ पे थ्रोम्बस था, ये सब कार्डियोलॉजिस्ट विल डिसाइड। उसके बाद फिर हाई इंटेंसिटी स्टैटिन पे शिफ्ट कर देते हैं धीरे धीरे। आपको एलडीएल मॉनिटर करना है पेशेंट का। एलडीएल लेवल्स मॉनिटर करने के बाद यू कैन शिफ्ट हिम टू द लोअर लेवल्स ऑफ एट्रोस स्टैटिन, सॉरी स्टैटिन, बट यू शुड डेफिनेटली कंटिन्यू स्टैटिन फॉर लाइफ लॉन्ग।
Yes.
एंड यूज ऑफ एसी इनहिबिटर, एआरबी, आरनी, बीटा ब्लॉकर, ये सब इको से भी आपको देखना है। इफ द इकोकार्डियोग्राफी सजेस्ट ऑफ ए हार्ट फेलियर with reduced ejection fraction, let us say 30% or 40, 35%, 40% like that, definitely you have to consider AC inhibitor or ARNI as well as beta blocker. If the ejection fraction remains normal, then you can do away, like do with minimum drugs like statin and antiplatelet only. But if the patient develops anginal symptoms, despite uh, despite the medical management, then you have to put the patient on anti anginals also. उसमें से हमने ऑप्शंस देखे थे, बीटा ब्लॉकर हो सकता है या फिर नॉवेल एंटी एंजाइनल एजेंट्स हो सकते हैं, जैसे रेनोलाइजिन हो गया, निकोरेंडिल हो गया, और इवन अपना एज ओल्ड नाइट्रेट जो है दैट कैन ऑल्सो बी यूज्ड।
Okay, calcium channel, yes. Now, next is coronary artery bypass grafting. It is a surgical procedure in which graft is used to bypass a blocked coronary artery. Graft is taken from left internal memory artery, which is best suitable, or the right internal memory artery, or radial artery, or great saphenous vein. So it is relatively safer, and mortality increases with advanced stage. And graft potency, the venous graft has 10 to 20% during first year, 2% for next 5 to 7 years, and 4% thereafter. And arterial graft are much better and have long-term patency. Then minimally invasive coronary artery bypass graft is done by small thoracotomy or off-pump surgery. It is CABG is more uh, preferred in diabetes patient with diabetes mellitus and multivessel coronary artery disease, uh, for few MI, less CVD, and better survival. So now PCI versus CABG. PCI is less invasive, no sternotomy, and fast recovery and lower initial cost. CABG has it is done for left main artery disease, three or more vessels are involved, or diabetes mellitus, and multivessel disease, coronary artery disease. CABG is done. Limitation of PCI is more repeated procedures are needed. Lesion, it is lesion focused, so treats the current blockage only, and it is indicated when single vessel disease is present, or two vessel disease are present in elderly or in severe comorbidities. PCI is done.
Nowadays the indications of PCI are increasing day by day, जैसे कि cardiologists are also going very frequently for multi-vessel PTCA, but classical teaching यही बोलता है कि if the disease is extensive, if disease is more proximal, or the patient is diabetic, or the patient has a severe triple vessel disease, या फिर failed PTCA है, या फिर difficult anatomy है, and definitely you can go with a CABG, early CABG। ठीक है, तो इस तरह से यू हैव टू बी वेरी अलर्ट, बिकॉज डूइंग पीटीसीए एंड देन हैविंग अ फेलियर एंड देन गोइंग फॉर सीएबीजी इटसेल्फ कैरीज अ लॉट ऑफ रिस्क। इंस्टेड ऑफ
Yes.
दैट, डूइंग सीएबीजी अंडर trained experienced CVTS surgeon is always better। ठीक है।
पीसीआई में रिकरेंस के चांसेस ज्यादा होते हैं ना?
पीसीआई में रिकरेंस का चांसेस होता है डिपेंडिंग ऑन द एनाटॉमी ऑल्सो, क्योंकि
हम्म
प्रॉक्सिमल डिसीज हो गया, एलएमसीए हो गया, या फिर एलएडी हो गया, उसमें ऑन टेबल मोर्टेलिटी भी कई बार हो सकता है। वी हैव टू
हम्म
बी वेरी अलर्ट। ऑल दिस
हम्म
कंडीशंस अगर है, ट्रिपल वेसल सीवियर ट्रिपल वेसल डिसीज है, तो एक अगर आप प्लास्टिक करने जाओगे, एम्बुला रप्चर होके बहुत सारे फिर अलग अलग आर्टरीज प्रीवियसली नॉट इन्वॉल्व होते, वहां पे भी जाके फिर पेशेंट कैन डिटोरिएट सडनली। ऐसे कंडीशन में तो एटलीस्ट डू अ पीटीसीए इन अ सेंटर वेयर सीवीटीएस सर्जन इज अवेलेबल, ये आप कर सकते हो। इन केस इफ देर इज नो अदर ऑप्शन, एटलीस्ट हैव अ सीवीटीएस बैकअप, बट
हम्म
वन शुड नॉट टेक रिस्क।
Also, I would like to add if patient is having suspected valvular heart disease, if having MSMR also, and also if he develop papillary muscle rupture. So rather than going for PCI, we can go for CABG and also side by side repair the valvular lesion also. So at that time, we will prefer CTVS CABG over PCI.
Yes.
Uh, the major part of treatment is done, Shri. Now,
ओके करेक्ट सो वही है कि लास्ट टेक होम मैसेज में एक बार बोल देता हूँ हिस्ट्री एग्जामिनेशन और ईसीजी के बाद आपको ट्रोपोनिन्स देखना है क्लासिफाई द पेशेंट इनटू acute coronary syndrome in what type if it is non ST elevation or ST elevation do thrombolysis get a PCI done according to the echo classify him into heart failure or not heart failure patient and then send him home with dual antiplatelet statins and plus minus AC inhibitor beta blocker most of the time everybody will be on and keep the patient on close follow-up. Lifestyle changes is very important. And if the patient develops a severe triple vessel disease or as Yash has mentioned, concomitant valvular heart disease or any other indications which is it is favorable to do a CABG, then go for CABG. ठीक है तो दिस वाज अबाउट इस्केमिक हार्ट डिसीज ऑब्वियसली लॉट ऑफ पॉइंट्स हमने ठीक तरह से नहीं कवर किया है बट यू हैव गॉट अ फेयर आइडिया अबाउट इट प्लीज ये टेक्स्ट बुक से और एक बार रीड करना वी विल कीप ऑन डिस्कसिंग इन डीएम इफ नेसेसरी एंड वी विल post this video in YouTube. You can share the link or revisit it if you have missed some points. Uh, Next topic we will be meeting on is about cardiomyopathies. We will share the date and time of the session very soon. Meanwhile, ISD के पूरे टॉपिक में कुछ भी क्वेश्चंस हो तो feel free to ask. And we will share the video soon. ठीक है? Thank you so much, Maithili, for this presentation. I hope you have shared the notes in the group. I will also share
yes,
these
yes,
notes with other people also who have been attending the session. Thank you so much.
yes. Thank you, thank you.
Oh,
Thank you, Yash. Valuable points
okay,
from
okay.
you.
Thank you. Thank you. Good session.
Thank you,
Great session.
thank you. So.